Thank you for tuning in to another episode of Watson Clinic Health Talk. We're recording this episode in May, which has been designated as National Skin Cancer Awareness Month. So we thought it would be a good time to discuss the measures you can take to protect yourself against the threat of skin cancer. And we have a wonderful guest to help us do that. Dr. William Roth is a board-certified dermatologist who treats patients from our Watson Clinic Bella Vista building location at 1755 North Florida Avenue in Lakeland, and from Watson Clinic Highlands at 2300 East County Road 540A in South Lakeland. In addition to his role as a practicing dermatologist, Dr. Roth also serves as the president and managing partner of Watson Clinic. Appointments with Dr. Roth or any member of his care team may be scheduled by calling 863-904-6201 or by visiting watsonclinic.com/Roth. I wanted to start by asking you about UV rays, because we hear a lot about the dangers of prolonged exposure to UV rays. What is that danger exactly?
Yeah, well, it's actually pretty straightforward. Ultraviolet light is radiation, which penetrates our skin and it travels into the depths of the skin, and it damages the DNA of individual skin cells. Our bodies have an ability to repair that damage, but over time and repeated exposure, we kind of fail or lose the ability in certain circumstances to correct that damage. Since ultraviolet light is radiation and it penetrates skin, there's no safe level of exposure, actually, because any light exposure will invariably contain ultraviolet during certain hours. I'll explain that in a little bit. And so there's no safe level of tanning, or some folks used to believe, not physicians, but patients and the general public, that, well, if you get a base tan or something, it'll protect you from further exposure. And the actual response of your body creating a tan is it's trying to protect itself against further damage. So you can't get a tan without first having damage to the DNA in your skin. And then it's a reactive response to try and prevent further penetration of ultraviolet.
So when you go out in that Florida sun, what are some basic protective measures that you should take?
Okay, well, there's multiple. And let me preface my comments by saying that we don't want everyone to become like vampires and only come out at night. That wouldn't be a great existence. We want people to get out and enjoy the outdoors and the sun. We live in a beautiful environment here in Florida, and we like people to take advantage of it. But you just need to protect yourself from really any excessive exposure. Obviously, a couple minutes here and there can be healthy for you. It helps create vitamin D, but we don't want it to a point where you're going to be having damage of your DNA in your skin cells that overwhelms the body's ability to repair it. So staying in the shade when you can, doing activities that aren't during the midpoint of the day. So whatever the solar maximum is, with the time changes right now, solar maximum is about 1 o'clock. So an hour before 1 and an hour after 1 o'clock, the strength of the ultraviolet is the same, and it waxes and wanes during the day. So if you were at this time of year conducting all of your outdoor activities before 9 or say after 5, then your UV exposure would be relatively low. As the angle of the sun increases towards sunset, or when it's just coming up in the morning, the ultraviolet doesn't penetrate the atmosphere quite as well. So that's another way you can protect yourself, is by doing those activities outside of the midpoint of the day, and obviously using sunscreen, and that's on all sun-exposed areas. It's not just your face. You got to remember your hands, your arms, your neck, your ears, the back of your neck, places where we frequently see skin cancer.
Would you recommend a SPF factor of 30 or over?
Yes. So that's an interesting question. When I started almost now 31 years ago, The American Academy of Dermatology recommendation was for SPF of 15 or higher. When I started, even though it was 15, I recommended 30 for all of our patients in Florida because the sun seems to be so much more intense here. The current recommendation, which was updated about 10 years after that, is a 30 or higher. And I personally recommend a 50 or higher for our patients. The reason for that is study after study, multiple studies have shown that people put on insufficient amounts of sunscreen. The studies that show what an SPF factor is for a particular sunscreen is done with a certain number of grams per square meter of skin. So it's very scientific. Our general population doesn't actually measure out the sunscreen quite the same way, and we tend to use a little less than what they use in the studies. So if you have a less than complete application of 50, maybe you still have enough on for a 30. So I personally use a 50. I recommend a 50 or higher. You would always want to use a broad spectrum sunscreen that will block both UVB, which is the main driver of skin cancer, as well as UVA rays, which can play a role in melanoma and also accelerate photoaging. So that's a reason to use a broad spectrum sunscreen that blocks both UVA and UVB. And one that's sweat-proof or waterproof would be helpful. The party line on reapplication is every 2 hours. That may be a little excessive. If you're not getting wet or you're not sweating or you're not rubbing your skin and rubbing the sort of sunscreen away, you could probably go a little longer than that. But if there's any question that it's being washed off or rubbed off, then you should reapply every couple of hours just to be safe.
Okay.
And as long as I'm along those lines, a personal preference for sunscreen is exactly that. It's a personal preference. Whether you should use a gel or a lotion or a cream. Some people like certain types of vehicles on their skin compared to others. Most men would prefer gels. They rub easier onto hair-bearing areas compared to a lotion. But that might be drying, so others might like lotions or creams. One I would not recommend, just so I'd like to put that out there, is the all too ubiquitous spray sunscreen, because people like to apply that spray out in the breeze and they sort of just wave it around in front of their face or their skin. And I can tell you that if anyone has ever spray painted something, you have to go slowly in broad strokes to get an adequate coat. And it's the same thing with spray sunscreen. So if you are going to use spray sunscreen, you really have to be very careful about using enough and not just sort of spraying it in the breeze and hoping enough lands on you.
Yeah. I also read about other recommendations like a wide-brimmed hat, long-sleeve clothing. But if you're applying that sunscreen liberally, long-sleeve clothing, you don't have to. You can still wear short sleeves or without a shirt if you're at the beach, for instance.
Yeah. That's correct. If you have an adequate amount of sunscreen coverage on any sun-exposed area, it should prevent and protect you from the effects of the ultraviolet. It's a lot easier to have a rash guard on or a T-shirt on or something that covers the larger parts of your body, especially like your back and things, so that and your shoulders are covered so that they don't get exposed. So I would recommend that. Now, it's very hot here in Florida in the summertime when the sun is very strong. To wear long sleeves out in the sun, can be very difficult for some people. It's very difficult for me.
Yeah, it does sound a little unrealistic.
And so I personally just make sure that I put adequate sunscreen on my hands and arms. Don't forget the backs of your hands. People always forget that we actually see a lot of skin cancer on the backs of hands.
So I want to know, for people out there that have never scheduled an appointment with a dermatologist, tell me what a dermatologist can do for you and how often you need to schedule with them.
Sure. Dermatology today is we're primary care physicians for your skin. There's, many years ago, people would probably never go to a dermatologist unless their primary care physician referred them. I think that was long before skin cancer became the scourge that it is. Skin cancer rates over the last couple of decades have really skyrocketed and are still going up. For someone who has no history of skin cancer, we would recommend a yearly examination. We would want you to be keeping an eye on your own skin on a regular basis. We recommend monthly self-checks. To do that properly, we have brochures in our office that show how to do it, but it actually requires a mirror to see parts of your body that are not normally visible to you. Having a significant other or spouse to help look at areas that are not easily seen by you. We have lots and lots of patients who have had skin cancers found by their spouses and significant others. Coming and seeing the dermatologist once a year, even if you've never had skin cancer, is a form of sort of preventive surveillance. Morbidity and mortality associated with skin cancer is completely preventable, or for the most part preventable, if you find things early. So the same way that women should get a mammogram every year over a certain age, and all of us should have colonoscopies every few years after a certain age. Certainly, even starting in your mid-20s, coming and seeing a dermatologist once a year is highly recommended, because we want, if you are unfortunate enough to develop something early, we would want to detect it early. And coming by once a year, letting us look you over, it's a very sort of a benign examination, just the sort of look-see once over, if there's nothing going on, is well worth the time and expense.
So starting in the mid-20s, you would recommend to start investing in annual evaluations at that point?
Yeah, I would, because there's no sort of time lag with certain skin cancers. I could talk about the major different types of skin cancer. Everything gets simplified in medicine. There's probably 23 types of skin cancer. It's just that many of the other types are not as common, where we see one or two a year, or maybe I see one every few years. But certainly the three types that are always in the media are the most common, and that's basal cell carcinoma, squamous cell carcinoma, and melanoma, melanoma being the most serious. So I'll start with basal cell, if that's okay. That's the most common. There's 3 to 4 million cases of basal cell carcinoma in the United States every year. Keeps us all very, very busy, I have to say. It's the quote-unquote good kind of skin cancer, because it really never spreads. So if left untreated, a basal cell carcinoma will just get bigger and bigger and deeper and eat away at whatever tissue it originated in. And therein lies the problem, because cancer by definition is destructive. A benign lesion will just grow in you, on you, next to you, and not disturb any of your normal tissues or organs. But cancer, as it grows, destroys the tissue that it's growing in. So that's the definition of cancer. It's not that it has to have the ability to spread. So that's what basal cell does. So you want to find them early, and you want to find them when they're small, so that the removal of them is less of a problem. And certainly when we're talking about facial lesions, it would, having them removed can be disfiguring or cause some dysfunction of the nose or the ear or the eyelid or something like that. So that's one reason to be surveilled. The second most common type of skin cancer is squamous cell carcinoma. And that arises in the intermediate layers of the skin. And if you read about it, it says they can metastasize. So squamous cell carcinoma has the ability to spread. The good news is that most squamous cell carcinomas on skin are very slow to develop that property. So when found early, they're removed in a similar fashion as a basal cell skin cancer. Excised, stitched, we check the margins, make sure it's all out, and then we really don't worry about them spreading unless they're in critical locations. Some of the critical locations would be like a lip or nostril, very thin skin, the rim of the ear, things like that, where they can get into deeper tissues earlier. But for the most part, we look at the risk level of those squamous cells, sort of the same as a basal cell, just a slight notch above. And statistically, in the past, there were 5 basal cells to every 1 squamous cell. I think, I haven't read a study on it very recently, but I would think that it's a lot more squamous cell carcinoma today than there was in the past. We see lots and lots. And then getting towards the third most common type of skin cancer, certainly in the media that we talk about all the time and is the most serious, is melanoma. Melanoma is cancer of the skin, but it's of the pigment cells in the skin, the melanocytes. And they have the ability to spread very quickly once the cancer develops. That's the type of skin cancer that you want to detect early, because if you get an early detection, 5-10 year survival rate will be in the upper 90s. But if it's detected late, that could drop precipitously. Whereas the damage from ultraviolet exposure leading to other skin cancers is a cumulative thing, which could take decades sometimes to show up, so that people in their 40s and 50s are the ones that maybe have a majority of those types of skin cancers. Melanoma, again, one of the most serious types, can come quite early and is as much related to family genetics as it is to sun exposure. There's definitely a family predilection towards individuals with excessive numbers of moles, or moles that are somewhat abnormal in appearance, and they have a genetic predisposition to developing melanoma with or without sun exposure. The sun exposure in those patients makes it more likely that they're going to get melanoma. The highest rate of melanoma in the world is in Australia, where you have a bunch of displaced Englishmen out in the Pacific sun. So the sun definitely plays a role, but family genetics also plays a role. So especially if you have large numbers of moles, or moles that are a little larger than average, you could have what's called atypical mole syndrome, and then you're at an increased risk right out of the gate. So certainly an initial screening examination in your 20s, you may not need one every year, at that early of an age, but things should be looked at, because you may have a situation where you'd want to be checked more frequently.
Sure. It's better to be safe. So in terms of self-skin checks, there's something called the ABCDEs of melanoma detection.
Yeah. Some people say ABCCD, and some people say ABCDE. I'll explain that. It used to just be ABCD. A stands, well, we're looking for pigmented lesions, so brown-black moles on your body. And A stands for asymmetry, so your moles are supposed to be symmetrical. If you run a line down a mole in any direction, one side should look like the other. Okay, that's symmetry, like a mirror image. B is for border. The border of a normal mole should be round. It should just sort of be like a circle and be smooth around all the way. An abnormal mole would have an irregular border, almost like looking at a coastline on a map, let's say. It doesn't just go straight along. So you don't want anything that has an irregular border. C is for color. Normal moles are typically monochromatic. They're one color brown. Now, some may be lighter brown, some may be a little darker brown, but they're one color brown. When you start noticing, or if you should notice, a mole that has multiple shades of brown or black or gray or blue, even some red, these are warning signs that mole is abnormal. Now the additional C is for change, and that corresponds to the E, by the way. So the E was evolution. Okay. So an evolving mole. So I kind of like change, the double C. Any mole that's changing, that's a concern right away.
Like changing in size and color, or?
Changing in size, changing in color, changing in its characteristics. If you have a mole that suddenly becomes inflamed or itchy, or really any change, they should just sit there and not bother you and not be noticeable to you really in any way. So any kind of changes, if they should bleed or scab or anything, then that's very concerning. And then D is the final thing, which is for diameter. Normal moles are the size of a pencil eraser or less. That's 6 millimeters. I mentioned earlier about people who have a genetic predisposition towards melanoma. They have larger numbers of moles, let's say more than 40 or 50 moles on their body, and then many of their moles are a little larger than normal. That doesn't mean that they're cancerous, but that's just sort of the way they're genetically predisposed. But those are the ABCDs of melanoma. Those are guidelines. Those are things that should raise your eyebrows. They're not, cut and dry always. I've seen melanoma that's smaller than 6 millimeters. I've seen melanoma that's sort of one color, but maybe very black appearing. So it's the media likes to simplify things, but there's exceptions to every rule, and kind of that's part of one's training and experience being in the field. There's one thing I want to mention too about the appearance of melanoma, which I feel is wrongly never mentioned in the media, and that is that a melanoma that's early, when you want to detect it when it's early, is flat. If you close your eyes and rub your finger across it, you will not feel anything. Okay? So it's a new pigmented spot, but it's a flat spot. Typically, 80% of the time, 80% of melanoma is a new spot. It's not a mole you have already. Your body is covered in mole cells. You only see them where they clump up, and that's your moles. But you have more mole cells between the moles than actually within them. So that's why the majority of melanoma is a new spot appearing. And it should be flat. If you have a melanoma and it's raised, and it's gotten to that point that you've kind of waited too long already, so you want to be aware of that.
So if you're doing a self-skin evaluation, or you schedule an appointment for your annual examination and there's an area of suspicion, what do you do? Do you remove it there in the office for testing? Or?
Well, for the most part, yes. We use our clinical judgment. When you're examining a patient for the first time, well, that's a snapshot, right? You don't know what's changed or is different from visit to visit. I don't know if the patients have even been self-aware up until that point, maybe, that they decided they should start looking into these things. But there are occasions where we will take photographs of some moles that are just sort of borderline. Mm-hmm. And then we'll say, well, why don't you come back in 3 or 4 months, and we'll just compare the pictures and see if there's any change, because it could possibly be, but probably not. But if there's really any question at all, then yes, we do a biopsy. And one of the nice things about dermatology is it's very easy to get a biopsy on a person. I kid around with patients. I say, well, it's not like we're going to do a lung biopsy or a brain biopsy on you. We're going to give you a little tiny pinch of lidocaine, little tiny pinch, and then we'll just take a little tiny, and we take the smallest little sample of skin because it's examined microscopically. We just need a little tiny piece to have a look-see. Mm-hmm. I mean, we can do biopsies that, they're thin. If you do a biopsy and you only get into the dermis, and the first third of the dermis, it doesn't scar, actually. So,
I also wanted to ask, because here's another service that we offer, Mohs micrographic surgery. What is that, and at what point would you refer a patient to that service?
Sure, that's a great question. There are multiple ways to treat skin cancer. Surgery is the number one method, primary method, because it has the highest cure rate. Cure rate statistically is 95% for cancers that are either excised and sewn back up, or treated with a procedure that we call ED&C, which stands for electrodesiccation and curettage, which is very fancy sounding, but basically it's kind of digging out the cancer out of the skin and then cauterizing the base to sort of increase the cure rate on that. It's very effective. It's very quick, but you wouldn't want to do that in places where it's cosmetically important. So that's why we have the two methods. And there are other pros and cons of the two methods. And then there's Mohs micrographic surgery, Mohs touts itself as having a higher cure rate, maybe 97, 98% as opposed to 95%. That differential is not that great, but it is better according to the literature. That's number one. And then number two, when done properly, Mohs surgery will have better tissue sparing, shall we call it, because they take very small little shave samples at a time and they check it, and then they see which edge has a little more, and then they check it again, and then they check it again. So theoretically, they take a minimal amount of tissue, as opposed to standard excision where you're just going to say, well, I'm going to take this spot and I'm going to take a few extra millimeters around, and that should get it. So there's a benefit to that too. The trade-off on that is that it's more expensive, obviously, and it takes much longer because you have to have pathologic analysis between every stage. So, but it certainly has its benefits, and certainly in places where a skin cancer has recurred, or in areas where you really want to try and spare as much tissue as possible. So, some of the areas I mentioned earlier, like an eyelid or a nostril or an earlobe or something like that.
So some of the other conditions that a dermatologist can treat include things like rosacea and acne and eczema, and they also treat disorders of the hair and nails, right?
Yeah, certainly hair and nails are appendages of skin, so that's all within our domain, yes.
Okay.
And even, regarding skin cancer, as I said in the beginning, the media always talks about these 3 types of skin cancer, but there's 23 to 25 different types of skin cancer. And like Merkel cell carcinoma led to the demise of Jimmy Buffett in the last couple of years, and everybody was scratching their heads saying, well, what is a Merkel cell carcinoma? But that's a skin cancer that derives from the nerve cells in the skin. And it's not common, and it's the kind of thing that maybe we see every 4 or 5 years. We see a single case, but it's actually a quite aggressive type of skin cancer, quite serious.
And he was the epitome of beach life.
Yes.
And plus the skin is the largest organ of your body, on your body. And so, of course, it would be open all number of different conditions and maladies, I would imagine.
Well, yeah, and it's a remarkable organ because it just protects us in so many ways. I mean, it keeps, to simplify it, it keeps everything out, and everything in. It's related to total water balance. It's, through transepidermal evaporation. It regulates your temperature, it regulates your immune system. When you have serious skin conditions that involve large portions of your skin at one time, now we're going away completely from skin cancer, obviously. The metabolic effects on your total body, very, very serious. Very serious. Put such a stress on your body if you can't thermoregulate, if you can't maintain your water balance, if your metabolic requirements go sky high because of the inflammation in the skin. So yeah, it's remarkable. One of the things that attracted me to dermatology, other than my own personal experiences, is that we have plenty of patients in the medical world that ignore symptoms, or there are silent disorders, high blood pressure, for instance. And when people get pre-diabetic, they don't really feel it, or, they have some stomach issues and they just ignore it. But when something appears on your skin and you see it on the outside, you seek attention because you can see it. And it's satisfying as a physician because you can also see when we make you better.
Well, Dr. Roth, it's been a pleasure. Thank you for coming in.
Well, again, thank you for having me. I enjoyed it.
Thank you for tuning in to this episode of Watson Clinic Health Talk. Appointments with Dr. Roth may be scheduled by calling 863-904-6201 or by visiting watsonclinic.com/Roth. And for more information on our entire dermatology department, which is housed in 6 convenient locations across Polk, Pasco, and Hillsborough counties, visit watsonclinic.com/dermatology.